Hello and welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and I'm on a mission to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be talking about neurology, we'll talk about MS, health and wellness, and we'll even throw a little bit of music and music therapy in there as well. Thank you all so much for joining us, and stay tuned for the next episode. Hello, happy new year, friends. Welcome to Brain Chat. I'm Dr. Mitzi, your board certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, I am so excited to be back with you all for our first episode of the new year, and we are going back to the basics. So, what is MS? Sometimes we get into these discussions where we talk about treatments, we talk about all these other things, but sometimes we just need to go back to the beginning, say, what's MS? What is it all about? Especially for those who are newly diagnosed, and even for those who've been diagnosed for a while, sometimes you'll learn something new. All right, so you know how we do. For those who've been to Brain Chat before, drop in the chat box where you are logging in from. I bid you greetings from a slightly chilly Atlanta, Georgia, and I am super duper excited about our show tonight and about the guest that I have with me. All right, so let's drop in the chat. I see you guys filtering in. Tell us where you're logging in from. All right. Okay. I got a fellow AT alien that's logging in. I see Detroit, where it probably is much colder than it is here in Atlanta. We've got Orlando. We've got another Atlanta. You guys keep dropping in the chat. And as you know, if you have questions, please feel free to put them in the chat and we'll answer and address them at the end in our Q&A session. So we'd love to hear from you guys. Thank you all so much for taking out your time on this Monday night. I see another Detroit. I see Abbeville, South Carolina. I see chilly Atlanta. I see Greensboro, North Carolina, Jacksonville, Florida, more Atlantas. All right. So you guys are logging in from all over. Okay. So I am going to bring up my guest who I'm super duper excited about, who is also a neighbor in a slightly chilly Atlanta, Dr. Jacqueline Rosenthal. She is a graduate of Xavier University with her Doctor of Medicine degree. She got it from Morehouse School of Medicine in Atlanta. MSM representing. She completed a residency at Madigan Army Medical Center in Tacoma, Washington. She also served as a fellow in neuroimmunology. So she is fellowship trained in neuroimmunology from Emory University and the Atlanta VA Medical Center. She served in the U.S. Army Reserves and the U.S. Army. Thank you for your service, Dr. Rosenthal. And after she completed her neurology training, she served as staff neurologist in the Army. She recently joined the staff of the Andrew C. Carlos Multiple Sclerosis Institute at the Shepherd Center in July 2019. And she is the coolest, and I am so excited to have her on tonight. Welcome, Dr. Jackie Rosenthal, everybody. Yay!
Thank you so much for having me here today.
Awesome sauce. Well, welcome to Brain Chat. I see you have someone else who's from Xavier logging in the chat. Some love there. I see a couple folks. All right, very cool.
Nice.
Okay, so let's hop into it. So first, tell me a little bit about yourself. Tell the people about yourself, Dr. Rosenthal. How did you get into MS?
So I initially wasn't going to go into MS. I was going to do general neurology, and my MS patients, you mentioned the military, so I would have them for a hot second and then they were gone out of the military and I wouldn't see them very much. And so being able to have that follow-up over time was something I wanted to do, and it really played a major role into my decision to get out of the military. So that's how I got here. Yeah.
Wow. Well, thank you for your service and thank you for your commitment to the MS community. All right. So we've got a very exciting kind of bread and butter topic that we're going to go to. One of the first questions that I ask every patient that comes to see me, whether they've had MS for 6 months, 6 weeks, or 16 years, is what is MS, right? And I want them to kind of give me an explanation so I can know what they understand about the disease. And you will be surprised, as I'm sure you have, that there are some people who've had MS for a very long time, but maybe can't quite explain what it is, or maybe don't know what it is. So tell us what MS is. What's MS?
Right. So and it's a super important and topic to discuss. But MS, so it's an immune disorder. And just looking at that, I think it's important to emphasize to patients immune dysfunction doesn't necessarily mean like immune deficient, right? So the immune
Right.
system is misbehaving, and what you're having is abnormal inflammation to parts of the central nervous system. So again, another piece of information that's important to discuss is central nervous system. That's what makes MS unique as an autoimmune disease. It's specific to the CNS, so brain, spinal cord, and optic nerves being the connection between your eyeball and your brain, right? That's what MS affects. And you get little areas of inflammation because your immune system is misbehaving again. And that those areas of inflammation lead to nerve damage. There's loss of the myelin. And we talk about the myelin a lot. A very common analogy is that it's the covering to like that, it's extension cord. You lose that covering, the signal doesn't go through very well. That may or may not lead to symptoms. Those symptoms can get better, which is what we talk about with relapsing remitting MS. They could not get better at all or anything in between, which is why MS is it's so variable between patients, right? And so the other important thing about, well, what is MS is it's not just a one-time thing. It's not just an illness that hits you one time and never comes back. It's ongoing. And so you get these little areas of inflammation anywhere in your central nervous system that occur at different periods of time. And that's really what we're looking at as neurologists. We're trying to establish that. We're doing all these studies and asking all these questions and looking at MRIs. So you get little areas of inflammation affecting different parts of their central nervous system at different times. And that's really what multiple sclerosis is.
Absolutely. So that I could not have said it better. So every neurologist has their own take on the myelin. So some people you use an extension cord. I use the headphones, my wireless headphones that usually are hanging around my neck. And then I use the example of if my daughter gets a hold of them and messes with them, there'll be various levels of damage. And if she really wants to get in trouble, she'll take a pair of scissors and cut them, and then they won't work at all. And so those are kind of the different levels of damage that can happen with the immune cells. But it really is, very essential for people to understand when they think immune system, they think immune compromised, right? But I tell people, as you've said, that your immune system is not compromised, it's doing the most, it's doing too much, right? And so the goal of treating it is to try to get it to do less so that it's not attacking you, but still able to do things like fight viruses and bacteria. So there are a couple things that you said that I want to circle back to. Let's go back to this word relapse, right? Or exacerbation. This is something that can often be very difficult to conceptualize or for people to understand. I've had some patients that come in and say, Dr. Williams, I have a relapse every day. And I'm like, well, that's not a relapse if it's every day. Or I had the same relapse, for 7 years, right? And so let's talk about, what does a relapse mean? What exactly does that mean? Relapse, exacerbation, or exasperation, as some people call it.
Or flare, because we have all these words,
flare
right?
up, right? Or flare up. Yeah.
Right. So they all mean the same thing. And a true MS relapse is typically, it's a new symptom, something you have not experienced before that lasts longer than 24 hours. And the 24 hours makes sense, right? Because if you think about what MS is and how there's that inflammation having, in the brain, and those symptoms come up, it'd be really hard for all of that to happen and go away in like an hour or two, right? And so that damage there is going to create at least 24 hours of symptoms. And again, it kind of goes back to where that spot is, wherever that spot of inflammation in your brain, spinal cord, or optic nerves is going to give a symptom. And it's important to really differentiate that from pseudo relapse, or what we think of as like a worsening in an old MS symptom. And while they can both be equally uncomfortable, from an MS standpoint, when we as neurologists are looking at everything and trying to make decisions about, hey, is your medication working appropriately? Or do we need to get you an MRI immediately? Or do I need to look for some other problem? It's important for us to try to differentiate. Is this a true MS relapse, meaning that there is somewhere going on a new lesion, a new area of inflammation? Or is this just an old symptom that is coming up because of some other external factor. Did you overexert yourself? Or did you get overheated? Are you having an infection or a fever or something going on like that? Where in that case, you're just having old symptoms come up because you're not feeling great, but it doesn't mean that the MS is progressing or that you're having new disease.
Absolutely. And that 24 hours is also key because sometimes you have good and bad days with MS, right? So I tell people kind of part of the whole process is some days, you'll wake up and your walking will just be off. And then you go through that day, you go to bed, you wake up the next day, you're back to your baseline, right? So that doesn't count as a relapse because there will be some mild, what we call fluctuation, just as a part of the disease. Like if you have any chronic condition, sometimes you wake up and you just feel crummy and you just get some rest and goes back to normal. I think the other piece is that typical relapses usually last several days to several weeks, right? So even though 24 hours is that cutoff, it's not like, oh my God, if it lasted 25 hours and 30 minutes, it's a relapse, right? So it's not quite that precise, right? It's like it's 25 hours, So usually, there's several days to several weeks, and there's a period of either improvement or stability. The other thing that's very important to point out, I usually point this out to my patients, is this concept of remission, right? Remission with MS is not necessarily like remission with cancer. It doesn't mean an absence of symptoms. It means a period of stability, right? So you could have a relapse, let's say numbness and tingling in an arm or leg that lasted, for several weeks, and maybe you got 80% better. And then for 6-7 months, you still have that little 20% left over. That's a remission, right? Because you're stable. It doesn't mean that everything went completely back to normal. And that's also very important, and why we want to prevent relapses, because they can have symptoms that are left over from them. The other thing is, you talked a little bit about the categories of MS. Let's go into a little bit more detail. So tell us a little bit about the different subtypes of MS. Everybody wants to know, doctor, what type of MS do I have? Do I have relapsing MS? Do I have progressive MS? What does that mean?
Right. And we don't make it easy because they keep changing the names.
They keep changing. Right. We change it like every couple of years. We change the definition. We add some new, we add a couple new words, RIS, CIS,
Right.
and we take them away. And, so neurologists like to make it complicated.
Right. So today, the main categories, really, I like to look at it in starting off as just two categories. You have relapsing remitting MS and you have progressive MS. And relapsing remitting MS is by far the most common. And really, we look at it as how the MS begins. And so a lot of people with MS, as they're talking to neurologists that treat MS, we kind of really hone in on, but how did it start? We want to know how it started.
Right. Go back to the beginning.
Go back to the beginning. And so when the MS starts off with a relapse, it means you have symptoms that come about. And as you said, afterwards, there's a period of stability. That symptom may have gotten all the way better. It may not have gotten better at all, but it was stable before that next attack or that next relapse hit. And that is, again, the most common type. 85 to 90% of MS is going to start off with relapses. Less common is progressive MS. So, 10 to 15% of people have progressive MS. And that is where you have symptoms that start, it's usually subtle, which can make it take a little bit longer to diagnose, but the symptoms they get worse and worse from the very beginning. And sometimes the progression is so slow that it does take a year or two almost to really kind of pick up on, hey, this is what's going on. But that is what we call primary progressive MS. It became progressive from the very beginning. So those are the kind of two types of MS we look at from the very beginning. So onset, was it relapsing remitting, primary progressive? Then if you look at relapsing remitting MS, a subset of people with relapsing remitting MS will start to have some progression over time in between relapses. And that's where secondary progressive MS comes in. Okay. And then they further complicated things recently with this inactive secondary progressive MS, active secondary progressive MS, which I think it doesn't mean quite as much to us for those that us treated. I think a lot of it has to do with research, but active means that you're still having new lesions, new relapses, new attacks, new, active inflammation in your brain MRI. Whereas inactive secondary progressive MS means your MRIs look pretty stable. You're not having any new symptoms, but you feel like you're just getting worse and worse over time. And I think one of the encouraging things is if you look at the natural history of MS, they used to say before, 80% of people are going to be secondary progressive MS after, 10 to 20 years. And that's just not what we're seeing anymore.
Right.
That has improved. And they are still, if you say 10 to 20 years, that takes a long time to pull that research. And we have all these treatments now, but some of the more recent numbers are, saying, oh, maybe it's just 15% or 30%. And who knows? I think the biggest thing to take out of that is if you get on treatment early, your chances of not going into secondary progressive MS are pretty high.
Yeah. Yeah, and we'll talk a little bit about the importance of treatment before we wind up. But yeah, I think that it's important to note that the treatments which have changed, and really there's been a revolution in the treatment for MS even over the past 10 years, have really changed what we call the natural history of the disease. So I always tell my patients people aren't as disabled in my lobby as they used to be. Now, there certainly are some, right, that have very aggressive disease, but things are changing. There's a lot of opportunity for people to do better. Now, we talked about the types of MS. Now, let's talk about these symptoms, right? So, inevitably, every time when outside was open that I would go give a talk, right? My medical assistant would say, hey, Dr. Williams, 5 people called who were friends of the people at the talk who saw those symptoms and said they needed to come see you because they thought they might have MS, right? And one of the difficulties with diagnosing MS is that the symptoms are very common to other conditions and can be mistaken for other diseases. And once we see that pattern of symptoms kind of coming back over and over again, it's able to be diagnosed. But let's talk about some of those symptoms. What are some of the first symptoms that people have that should concern them to go see a neurologist?
Yeah, so I think some of the more important things to look out for when you're thinking about multiple sclerosis are things that could be directly from those attacks we talk about, right? So MS, it likes the optic nerve, so that's where we talk about this
Mhm.
optic neuritis, and so that's
Yeah.
typically where you lose vision. With MS, it's typically one eye. Rarely it could be both eyes, but even when it's both eyes, it usually gets one eye first and one eye worse. But kind of a pressure or pain behind the eye with loss of acuity or difficulty or blurriness out of that eye. So if you ever have symptoms like that, that should be worked up and looked at. It can also cause symptoms from the brain and spinal cord, weakness, one side of the body or the legs, arm, loss of coordination. There can be numbness, tingling. There can be bladder symptoms. I mean, it really, if you think about, and this is where we talk about, mimickers, but anywhere along what we call the neuroaxis, right? Optic nerves, brain, spinal cord, anywhere along there can give you symptoms that could potentially indicate MS.
Yeah, absolutely. And, one of the things about it is that I encourage people, if you have neurologic symptoms, please don't ignore them, right? One of the things that's, again, very difficult about MS is, for instance, I've had many patients who've said, I had a numb arm. I went to the doctor. They said maybe it was a pinched nerve and it went away, and I never followed up, right? So that follow up is extremely important, just to make sure, that everything's okay. And so I encourage people, if you have neurologic symptoms, things that are not normal, it doesn't hurt to give your primary care doctor a call, just to get it checked out to make sure. I
Absolutely.
think the other piece is that when we talk about diagnosing MS, one of the things that's very important to recognize is who gets MS, and that is anybody can get MS. Previously we used to think that certain populations only got MS. MS was thought to be a young white woman's disease, but there's data that that suggests that the risk is highest in Black women, and that the incidence is highest in Black people, primarily Black women. And so it's very important to not ignore your body. You are your own expert, the best expert on your body. And if you're having things that are going wrong, it's important to get that checked out and to seek some type of medical advice, to make sure, that you know what's going on.
Mhm.
And so, we talked about some of the symptoms that are very easy to see with MS. If someone has vision difficulty, if someone has weakness, those are things that are very easy for people to understand. that is some that that are things that are disabling. What about the silent symptoms of MS? And so I'm going to do a symptom series a little bit later on in the year, but some of those silent symptoms of MS are things that people may not think of as symptoms of their MS that really can affect their everyday function.
Absolutely. So fatigue is probably the most common silent symptom, and it's complicated by all of the other things that go along with MS, a lot of other silent symptoms. So difficulty sleeping, and MS
Yeah,
patients are more likely to get restless leg syndrome and suffer from
absolutely.
pain, nerve pain. You can have,
Hmm.
muscle cramp, stiffness, that sort of thing can keep someone up at night. And so they all kind of play off on each other, making it sometimes very difficult to treat. But it does highlight the importance of addressing those symptoms, as it relates to wellness and that sort of thing. There's cognitive symptoms. That's another one.
Right.
So probably the most common cognitive complaint that we see in MS patients, just a slowed processing speed. And it's not like
Hmm.
this downhill decline to where you're just demented. No, it's this kind of annoying background. It kind of plateaus of just not, just taking a little bit longer to focus on certain tasks. Um,
Absolutely. Word
yeah,
finding difficulty. Sometimes people have that word that's on the tip of their tongue and they can't get it out, or, may not be able to recall things as quickly.
yeah, absolutely. Some of the bladder symptoms, and again, that's another
Hmm.
one that can certainly impair sleep. So a lot of these mood symptoms is another one, right? So depression,
Absolutely.
anxiety, and they all again they all play off on each other and kind of create these symptoms that don't necessarily correlate to MRIs. So
Right.
someone can come in
Right.
and they're feeling worse and having symptoms, and we're like, well, your MRI is stable. Well, these other symptoms can still happen, and so that really highlights the importance of symptomatic treatment.
Absolutely, because I always tell people the way that we know things are working is we look at you and we look at your MRIs, right? So we look at the MRIs because sometimes they can give us information um, about the disease, even if you're feeling well, but you can also give us information about how you're doing. Even if your MRIs are stable. So that leads into diagnosis. So, how do we diagnose MS, right? Dr. Rosenthal, who's the person, I have lots of people that say, Dr. Mitzi, can I have MS and not have the spots? Right. And so let's talk a little bit about diagnosis. My general approach is you got to have something there on the MRI plus some type of symptoms, right? The two go together, right? It's very difficult to make an MS diagnosis with only one or the other. What's your approach?
Absolutely. I think that now with how advanced the MRI technology is, it really does aid us a lot, and the spots are necessary, right?
They're
And I
necessary.
think, and on the flip side of that, I just, want to briefly say that the spots don't necessarily equal MS. I'm sure you've
Absolutely.
gotten referrals, and I get a lot too, for people with MS because they have spots.
Hmm.
And there are so many other reasons you could have spots. If you have spots on your brain, anybody, you probably don't have MS.
Right.
Migraine, high blood pressure, high cholesterol, diabetes, history of tobacco use, all of these things can cause spots far more
Absolutely.
commonly than multiple sclerosis. So really, it's having a combination of those MRI findings and, like you said, having symptoms to go along with it. So when I see someone,
Hmm.
I always tell them there's not one test I can do that's going to say you have MS or
Right.
you don't.
Right.
It's overdiagnosed, it's underdiagnosed because for that reason. And so it's a combination of what you tell me as a patient, what I see on exam, what the MRI shows. If you decide to
Right.
get a lumbar puncture, what does that show? We kind of put
Right.
it all together and
Right.
say, does this fit?
Right, exactly. So it all has to fit together. So the lumbar puncture is kind of the icing on the cake, right? So also a lot of times I have folks who have this misconception that my lumbar puncture was negative, so they said I didn't have MS, right? So lumbar puncture helps if it's positive, right? But if it's negative, now it is positive in the majority of cases of people with MS, but if it's negative, it doesn't necessarily mean you don't have MS. So again, you need someone who knows about MS to kind of put these pieces together and determine if there's a diagnosis or if there's not a diagnosis. So the tests that we use are MRIs, which everybody loves going in the machine with the knocking sound, right? So there are MRIs that we use. We look at the brain. Sometimes we look at the spine. Also, other tests like a physical exam, right? So your doctor needs to see you, do a physical exam. Sometimes a lumbar puncture will help. Sometimes there are other tests that we can do for the vision called like visual evoked potentials. Sometimes a person can have very subtle damage to those optic nerves, but maybe didn't have a total loss of vision in one eye or the other eye. The other thing to keep in mind is that sometimes people forget, right? If you had symptoms 5 years ago, 8 years ago, and something went numb for a week and it went away, you may have forgotten about it. So that's why it's important for us to do that workup to make sure that we're not missing anything. So we talked a little bit also about mimics or diseases that mimic MS. What are some of the common diseases that may be mistaken or conditions that may be mistaken for multiple sclerosis?
So I think, again, just some of those, when we talk about having an abnormal MRI, some of those things I mentioned that can cause spots
Mhm.
oftentimes will kind of trick people a little bit and think maybe is there MS going on. There are other demyelinating disorders that affect the central nervous system that can look like MS. Um,
Mhm.
that are oftentimes still treated similarly. And so those are going to be things like neuromyelitis optica or Mogg antibody disease. And then the interesting thing is that I always say with those, those were things that we just, recently, and especially in Mogg, to kind of discovered as a clinically distinct syndrome from MS, whereas before and
Right.
long ago, even with NMO, it was thought to be just a really aggressive MS variant. I think it
Absolutely.
highlights the fact that we're still discovering antibodies and things that we can pull out from this MS umbrella and say this is a separate syndrome. So it does get
Absolutely.
complicated. But
Yeah.
then if you look at just the kind of the more vague symptoms of MS, the fatigue or numbness and tingling and that sort of thing. I mean, even migraine, for example, could present very similarly. Just looking at other autoimmune diseases, right? So, lupus, Sjogren's, and these sorts of things can also cause brain lesions and a lot of other symptoms. And so the path towards MS can be complicated based on, what all someone's medical history shows.
Right.
Um, Again, I think it just highlights the importance of putting all that information together, getting the history, doing the physical exam, getting the MRI, and then seeking out a specialist to kind of put it together to make sure that that's what's going on.
Absolutely. And so NMO, which you mentioned, neuromyelitis optica, or as we used to call it, DeVick's disease, used to be considered a part of MS, but in the 2010s or so, it became very apparent that it actually is a separate disease. And basically, it also leads to demyelination, but it primarily affects the nerves to the eye, the optic nerves, and the spinal cord. So we don't see as much involvement in the brain with neuromyelitis optica and anti-Mogg disease. And those diseases actually have an antibody that we can test to see if it's positive. And that's one of the difficulties with MS is that we don't have an antibody that we can check like we can for most other autoimmune diseases. But hopefully, our colleagues who are working in that lab will have one for us sooner rather than later. But yeah, so those are some of the things that can mimic. And then also, a lot of times when people come in to see me, they'll say, Doctor, I was diagnosed. They told me I had a pinched nerve, right? So maybe my leg got numb and they did an x ray and I had a little arthritis in my spine. And so they said maybe that was it and it went away. Or I've had people who've been misdiagnosed with stroke and gone into the hospital with symptoms, thought to have a stroke. And when they got that MRI, it looked like MS and didn't look like a stroke. So again, there are other things that are commonly mistaken for multiple sclerosis.
Biopsies. I've had patients that get gotten their spinal
Yes,
cord
absolutely.
biopsied because they thought it was a
Oh my
spinal cord
God, spinal
tumor.
cord biopsy. Oh
It
gosh.
was a MS lesion. Yeah. So they could.
Yeah. Yeah. So sometimes you can also have what we call tumefactive MS, where they get
Mhm.
that MRI and it looks like a tumor or some type of cancer, and so they have to do a biopsy. So that's very rare. So I tell most people that we're not going to do a biopsy, right? So, the only way to tell 100% what a lesion is to do a biopsy, but by and large, it's very
No.
rare that someone actually has to have a brain
We
biopsy.
try to avoid
Um,
that.
we at all costs, right? So that is going to be the super duper last option, right? But in some cases, it is needed to make sure that person doesn't have cancer. And that's also where that lumbar puncture comes in, because if we think someone has cancer, sometimes we'll see the cells in the lumbar puncture as well. And then what about ADEM? Can we talk a little bit about that before we move on?
Yeah, so ADM, so it stands for acute disseminated encephalomyelitis, and
Say
that
that three
is,
times fast.
I know. So that is different from MS because it really is what we
Mhm.
call more of this monophasic disease. It's not something that
Mhm.
is expected to recur or, cause a problem for the rest of your life, but it is something that can look like a first attack of MS. It is different in a few ways. One is that it tends to affect younger people, children especially, more than adults.
Mhm.
And when it comes about, it's usually a little bit more of a dramatic presentation. There's a lot of what
Mhm.
we call encephalopathy, which means confusion and just kind of being out of it that goes along with it.
Yeah,
There can be a lot more lesions with it, associated with it.
absolutely.
And but again, they kind of have this arbitrary, 3 month, whatever happens in that 3 months was this one episode, and then they don't, and it's treated. But after that 3 months, it's not expected to recur.
Right.
And that person doesn't need lifelong treatment. They've also looked at what can potentially trigger ADEM. So they've looked at, it as a result of vaccinations in very rare cases, or
Mhm.
being post-infectious
Mhm.
as well. But yeah, it's different because again, it's not something that would require indefinite treatment.
Absolutely. Yeah, so those are some of the different autoimmune, CNS demyelinating diseases. Now, let's talk a little bit about before we go to Q&A because I see a couple of questions in the chat. You guys can keep dropping those questions in the chat if you have any. We're happy to answer those before the end of the podcast. But let's talk a little bit about what causes MS, right? One of the things that I definitely try to emphasize to my patients is that there's nothing that you did to cause MS, right? But what are some of the things that increase the risk for MS, or do we know the cause for MS?
So we don't know the cause, but we know
Absolutely.
all of these different things that potentially lead to it. And it's not just one.
Right.
So there's appears to be this genetic predisposition, but that's not enough by itself. So they found over 200 different, genetic variations that have been associated with the disease. But if it's so many that if that automatically led to MS, we would all have MS.
Absolutely.
And so there's that genetic predisposition. And then on top of that, you take in, environmental factors, how much vitamin D were you exposed to? How much sunlight were you exposed to? Where did you grow up? And
Mhm.
then they think there's probably some sort of maybe immune trigger. Was there a virus or an infection or something you were exposed to that on top of those other genetic predispositions and environmental factors that together kind of made this perfect imperfect storm that set your immune system to kind of, as you say, go beyond 10. And this is
Exactly. Your immune system is on 10. And so, the virus that they talk about most commonly associated is Epstein-Barr virus. When I was in high school, it can cause mono, which when I was in high school, these called the kissing disease, right? Somebody was out for 2 weeks because they were kissing. But that is one that's been associated with increased risk for MS. But there's a lot that we don't know. And then there are also these modifiable risk factors, right? So we think about the things that we can't change, like genetics. We don't get to pick where we grow up necessarily. But then there are also these modifiable risk factors like smoking, right? Can increase the risk for MS, can also increase the speed at which you transition from that relapsing to secondary progressive disease. There are also things like obesity, which can increase risk for MS, especially at the younger ages. So we have these things that we can control, and then we have these things that we can't necessarily control that all can contribute. And there's a lot that we don't understand, but I would say the understanding has come a long, long way in a short period of time. So I'm very hopeful, that many of us that work in the scientific side and research and studies will help find some of these answers fairly quickly. All right. And then last thing I think we want to talk about before we take a couple of questions is what about treatment, right? So we're not going to talk specifically about treatments today, but what's the importance of treatment? So I have, so after we go through the whole, what is MS? What can happen? A lot of people say, hey, Dr. Williams, I just want to eat, if I eat this or that or eat my Brussels sprouts, will that make it go away, right? So how do we address kind of the balance between, natural things that we can do versus medications for treatment of MS, or what's your approach to that?
I definitely try to um, combine as possible. I don't think for the majority of people that natural can replace our disease modifying treatments, but I think using them in conjunction can be effective and helpful. And the main reason for these disease modifying treatments really is just to try to prevent the disease from getting worse. I always have to try to emphasize to patients, it's not going to make the symptoms that are there get better, but it really is to prevent you from getting worse, from accruing any sort of disability. And the medications that we have, the majority of them, I mean, for most people, they work really well to accomplish that goal.
Mm-hmm. Absolutely. So I think, when I have treatment conversations with my patients, I definitely try to talk about a holistic approach, right? Medicine plays a part. If you've ever seen a video with Dr. Mitzi, I say this like every time I talk, right? Medicine plays a part and you play a part, right? No medicine gets rid of the part that you play in your own health. And that's doing things like eating a healthy, well-balanced diet, exercising, making sure you're taking care of yourself, going to see your primary care doctor because we don't want to treat your hypertension and your diabetes. Your neurologist does not want to treat that, right? So make sure you're seeing your primary care doctor and checking on those other conditions and getting your screenings. But it is also important to use disease modifying therapies. And one way that I frame it is that we have known about MS since the 1800s, right? 1868, MS was recognized as a disease. There was no approved therapy until 1993. So we know how people do without therapy because for the majority of the time that we've known about MS, we've not had anything to treat it with, right? And so we do know that with treatment, people do better. And we know that we actually can see a change in the natural history of the disease where less people are developing progression and having as much disability. Now, at the end of the day, everybody has to sit down with their own healthcare provider, their neurologist, make the decision that's right for them. But it is important to know that most of the time we can find something that a person can tolerate that also will treat their MS. So having that combination of things often, I found in my experience, has been the best approach to treating MS.
I agree. And I think just highlighting the finding the best option, there's a lot of options and it's overwhelming, but there's also a lot of options. And so
Yeah.
if one
Yeah.
doesn't work, if you're not
Move
feeling it, we
on.
can try something different. We can
Exactly.
find something that
Exactly. The
works.
plan is not written in stone. My two
Right.
rules of thumb. Plan is not written in stone. So that means if we try something that's not working, we try something else, we move on, right? But that's also why it's important to stay in touch with your healthcare provider, make sure you're checking in with them. If you can see an MS specialist, it's great to see an MS specialist at least once during the course of your treatment or your journey with MS. But certainly there are many amazing general neurologists who are treating MS very well as well. All right. So with that being said, let's get to this Q&A. So I see a couple of questions in the chat. Okay. And so I'll go through a couple of these. So the first one is if you've never had MS, I'll post it at the bottom. Is this something that can happen to senior adults? I'll let you start on that one, Dr. Rosenthal.
Yes. It absolutely
Depends on
is.
what you consider senior. Now, the older I get, the older senior actually is. So now senior is like 90, right? Anybody under 90 is like young. They were so young. So, it depends on what you consider senior.
Yeah. But absolutely, I think, I've had someone in their 70s and 80s that was just diagnosed. And sometimes it's because it was the first attack, which is not common, but not
Right.
impossible. Sometimes
Right.
it's because it was just undiagnosed for a while and it was just finally kind of put together. But it can happen. I think the biggest thing to highlight is when you have someone that is kind of in the older phase of life, that's coming in for a potential MS diagnosis, is that you do have to kind of entertain some other possibilities. But at the end of the day, it's very possible to be older and still outside of that what typical window. A lot of people like to quote, that 20 to 40 or 20 to 50, and
Yeah.
you can absolutely still have MS.
Absolutely. Absolutely. All right. Next question. Why is it challenging for doctors or neurologists to diagnose? So I'll start off on that one. So, one of the reasons is that, again, it can mimic other conditions, right? And so it really depends on why someone's coming in, right? If someone's coming in because they have some white spots on the brain but no symptoms, then we have to look at the reasons why they may have those white spots. If someone is coming in with certain symptoms, but the MRI doesn't match up, there's some people who have certain symptoms and they'll have an MRI and it won't be normal, but it won't match the symptoms they have, right? So we kind of have to look at all of those things together: the MRI, the symptoms, the physical exam, any other tests, any other conditions they have, and make sure that we are excluding other reasonable causes for people to have those symptoms. That's why there's blood work that's done. We look at vitamin D, vitamin B12. We check all kind of antibodies and screen just to make sure we're not missing something else that will be a reasonable explanation for those symptoms. Any thoughts that you have, Dr. Rosenthal, about that? Why it's so hard to diagnose sometimes?
No, I agree. Again, with some of those other diseases where you could just do one test and it can give you your answer. Again, with MS, there's so many vague, non-specific symptoms. It can sometimes take some additional time for sure.
Absolutely. All right, next question. What color do the spots have to be? Because I've had white spots or no spots. So when we look at the MRIs, the spots appear white because of the removal or absence of myelin. So normally when we look at MRIs or pictures of the brain should be gray. It should be, I won't say 50 shades of gray, but varying shades of gray. It should be varying shades of gray. Oh, Dr. Mitzi's on one today. So it should be varying shades of gray. So when we see those white spots, it basically tells us that there has been some damage there, right? And in the case of MS, it means the removal or absence of the myelin, which shows up white, right? Because it should be gray. So everybody pretty much has white spots because those are only spots that we can see on the MRI are white. Or sometimes we can see black spots, and those are spots that tell us about more severe damage that's been done to the brain. But generally, we primarily look for the white spots, and then we also sometimes can see black spots. All right, I'll give this to you, Dr. Rosenthal. Why is anti-Mogg and MS often misdiagnosed as one or the other?
This is an interesting question because I think this is coming up a lot more. And
yes,
the reason
because
is
we didn't know about anti-Mogg. You couldn't even test for anti-Mogg until a couple years ago. It was like a theoretical thing
right.
until,
Yeah.
very recently.
So that test, it became commercialized just a few years ago. And so not even a few, like 3 years
like
ago.
1 or 2.
So, there's a lot of patients who have been thought to have MS for years. And now we have this test we can get and we find out that, it is Mogg, but it's just because we didn't have the test available before and it wasn't recognized as distinct before. It's rare to have the converse where you have Mogg misdiagnosed as MS because we have that antibody test. So that it kind of simplifies the diagnosis really because you do a blood test.
Right. Absolutely. Okay. Next one is, how can you get your primary care doctor, primary care provider, and neurologist to coordinate and exchange information about your status? So this is a bit of a difficult one. If you are being seen in a healthcare system where everybody can see everybody's notes, like a university or a hospital system, it makes it very easy. So for instance, when I was working at Grady Hospital here in Atlanta, if the patient has a primary care doctor, I can just log in and see the notes and see everything that was done. If your doctors are spread out and in different systems, it makes it a little bit more difficult. Unfortunately, the onus or the responsibility kind of winds up being on the patient to say, hey, doctor, can you send my notes to my primary care provider? And most people are fine doing that. But unfortunately, right now, it often is not a automatic thing for everyone, to send those notes. So, but most of the time, if you ask and say, hey, can you send my notes, to my other doctor, most people, would be happy to do that for you. Do you have anything, any other tips, Dr. Rosenthal?
That's the primary one. Again, it is really helpful. I have patients now that will kind of ask, who should I go to for a PCP? And then sometimes my answer is, if someone who's on the same system, we can share records, and it really can be helpful.
Absolutely. Absolutely. Yes. Yes. So someone within the same system absolutely can be helpful. Yeah, absolutely. All right. And how about here's another question. How does where you grow up affect the disease? So there are studies that were done, looking at where people grew up and where they lived before and after the age of 15. And so what they found was that after the age of 15, and some of these really old studies, is that you kind of took on the risk. So if you lived basically kind of grew up in a certain place where you're a young teenager, young adult, you took on the risk of wherever you lived, right? And so if you move from a low risk place to a higher risk place, then you tended to have that higher risk of MS if you moved at a younger age, and vice versa. The other thing that's been looked at is that the further you are away from the equator, the higher the risk of MS. So we see a lot higher risk of MS in like Northern Europe, but we also see pretty decent risk or high risk in Canada and the United States. And so that may have to do with some environmental factor. It may have to do with vitamin D levels. We don't see a lot of MS, let's say, in South Africa, but certainly we see a lot more the further away we get from the equator. All righty. So, how about here's another question. What are common bladder symptoms you see with MS? That's a good one.
Right. So, usually it's one of two problems or something in between, but it's a problem keeping it in or it's a problem getting it out.
Yeah,
And
I say gotta go, gotta go, gotta go, or gotta go and can't go.
yeah, and so that's that kind of that urgency where you can't hold it to get there, or the retention where you want to empty and you can't. Out of those
Mhm.
two, obviously the retention is a lot more concerning to us because when that urine is just kind of sitting there in the bladder, it really does put you at risk for a urinary tract infection. And so I always tell
Yeah,
patients, that's going to be the more concerning symptom that we want to be a little bit more aggressive in treating. But there are treatments for both. Unfortunately, sometimes you can have both going on. They gotta
yeah,
go, and I can't get it out. And that
yeah.
does complicate treatment because if I give you a
Mhm.
medication to help you go, then it's going to make the getting it out, they kind of compete with each other. That's really where a
Absolutely.
urologist comes in to help because sometimes there needs to be some
Absolutely.
additional testing to kind of figure out where's the predominant problem and to kind of tackle that first.
Absolutely, absolutely. So that's where we call our colleagues, right? We call the cavalry in and maybe get a second opinion. So we got a lot of questions, all right? So we're going to try to zip through some of these. All right. So can MS mimic post polio syndrome? So I am not quite as familiar with post polio syndrome, but generally the symptoms from polio are what we would probably call monophasic, like they happen and someone may have a severe disability and that winds up being fairly stable. One of the other key features, or one of the key features of MS, is that it's dynamic, right? You have symptoms that come and symptoms that go, or you have symptoms that progressively get worse. So the thing about MS is that there generally is change. It's not something that's often static or stable once it happens. For instance, you may think maybe stroke symptoms may mimic post polio, where you have something that's fixed and doesn't kind of get better or doesn't get worse. But MS kind of has that dynamic to it that's a little bit different. All right. What about vertigo? Can vertigo be a symptom?
Yes, it can
Yes,
absolutely be a system. Yeah, a symptom.
absolutely.
I
Absolutely.
think I think vertigo, and I kind of skipped down to one of those questions that's asking us about vertigo, but I think that it can be confusing because it's so common. There's so many things that can cause vertigo. You could have vertigo from an inner ear problem. You could have vertigo from a brain problem. You could have vertigo just because you were born with a predisposition to vertigo. It could be from
Right.
migraine. And so that's
Right.
where it sometimes gets a little hard with vertigo by itself. Um, as a first symptom of MS, for example, that can create some confusion in terms of coming up with a diagnosis. But vertigo is something I think we commonly see with MS.
Absolutely. All right. And then we'll take this question. So that pretty much answered the other vertigo question. Can lesions dry up or disappear? And that's a great question I get very commonly. So, in the acute phase, right, if we got an MRI today, and let's say you had a lesion that was large, or those lesions that were lighting up with contrast, meaning there was new inflammation or inflammatory activity. Sometimes between that scan and the next one, we will sometimes see lesions get a little bit smaller, right? Because if you think about inflammation, if you get a cut or something on your hand, first it might be big and swollen, and then it kind of, you know, decreases in size and you may wind up with a scar. But generally, if you've had spots, let's say for 5 years or 10 years, those don't tend to change over time, right? So if you had the same spot in the same place, you know, they usually would tend to get bigger, but don't as commonly get smaller, right? So in the acute phase, yes, between one scan and the other, if something's new, it can get a little smaller. But if they've been there for 5, 10 years, they're probably not going to decrease in size, and they may increase, in fact. And then the last one, I'll put up this comment, is that there's a pretty decent risk for MS in Nigeria now. And so we are learning more about MS on the African continent. I'm very fortunate to head up a clinical trial where we're looking at MS in Black and Hispanic patients, and we do have a cohort uh, in Africa. And so we're looking forward to finding out some of the results from that. And so, certainly we're learning more and more. We know the risk is higher in Black people here in the US. And as more resources are spread, to different parts around the world, we're hoping to better understand MS in some of those places where we've not understood it very well before. So, any parting thoughts, Dr. Rosenthal? We took almost the whole hour. I mean, people had great questions today. So, any parting thoughts or things you want to leave with folks about MS diagnosis and the importance of getting plugged in with a neurologist and following on a regular basis?
Just that, I think it's so important when you have MS, especially when you're first diagnosed, to really get that understanding. It's so hard in the beginning. I think that a lot of patients, you don't know what's going on. Is this a relapse? Is it an old symptom? Is my whole world going to implode? And it gets so much better over time
Right.
once you realize your body and what's a concerning symptom and what's not. But it's important during that adjustment period to really talk with
Mhm.
your doctor, get a sense of what MS is, try to learn how the disease typically behaves so that it'll help, I think, you as a patient to better understand what to expect moving forward and what are things that you need to maybe pay a little bit more attention to.
Absolutely. And my parting thoughts are, again, get plugged in with a neurologist. If you can see an MS specialist, that'd be great. But just make sure that you follow up, right? MS is a lot about what we call shared decision making. That means you sit down with your doctor and you guys come together and come up with the best plan for you. And that may look very different than someone else's plan. If I've seen one person with MS, or if you've met one person with MS, you have met one person with MS, because everybody is very different. So you have to come up with those conclusions and make those decisions with your healthcare provider that are best for you. So thank you all very, very much for your time and your attention. I am super duper excited. We had an amazing first episode of Brain Chat. Please don't forget to share with your friends if you felt like it was informative. Share with others. Let people know about the podcast. This will air. This will be live on all podcast platforms, on Spotify, Apple Podcasts, within a week or so. And you can just look for Brain Chat and please subscribe. All right. Thank you all so much. And we will see you in 2 weeks, where we will be doing MS 101 or MS 102, where we will be talking about treatments. All right. Everyone have a great night. And thank you so much for tuning in.
Bye.
Bye, everybody.